So what is myelodysplasia? Myelodysplasia is defined as defective development of any part, especially the lower segments of the spinal cord. And you may have heard the term spina bifida. That's sort of the more commonly used term. And spina bifida is the term used to refer to various forms of myelodysplasia. Spina bifida is classified into aperta, which means visible or open, and occulta, which means closed or not visible or open. And this figure shows a picture of what the different forms of spina bifida may look like. So when you look here, figure A shows spina bifida occulta, and again that refers to a closed lesion. It can refer to a lipoma, which can be small or large subcutaneous masses of fat. Lipomas are often associated with abnormal pigmentation of the skin, hirsutism, skin appendages, and dimples above the gluteal cleft. And you'll see in figure A, it actually shows a little tuft of hair that's commonly seen in closed spina bifida. They can also be lipomyelomeningocele with paralysis, lipomeningocele without paralysis, lipomas of the phylum Terminale, usually with no paralysis, lipomas of cauda equina or the conus medullaris with or without paralysis at birth. So there's various forms of spina bifida occulta. Spina bifida aperta, which refers to an open lesion, is shown in figures B, C, and D. And spina bifida aperta usually is categorized as a myelomeningocele, which is shown here in figure C. Myelomeningocele are open spinal cord defects that usually protrude dorsally. They are not skin covered, and they are associated with spinal nerve paralysis. Meningocele, which are shown in figure B, are skin covered. They're initially associated with no paralysis, and the meningocele usually contain only membranes or non-functional nerves that end in the sac wall. So paralysis may be acquired over time, although there is initially no paralysis. So what causes spina bifida? Well, spina bifida is thought to occur during neural tube formation, which actually happens in the first couple of weeks after conception. And there are two kind of parts to neural tube formation. First is neurulation. Neurulation is the folding of the ectoderm on each side of the primitive spinal cord to form a tube that extends from the hindbrain to S2. This occurs before gestational day 28, and it's associated with problems with neurulation are associated with encephaloceles and myelomeningocele, which typically occur from C1 to S2. So the majority of what we see in terms of spina bifida are due to problems with neurulation. Canalization is when nerve cells fuse together to become the distal end of the spinal cord, distal to S2. These lesions, when canalization doesn't occur properly, are usually associated with skin-covered meningocele and lipomas of the spinal cord, which frequently form caudal to L3. There are a number of potential causes for spina bifida. First, it can be genetic. Myelodysplasia is often associated with chromosomal abnormalities and other syndromes. So a lot of times when we have other genetic syndromes, we also see myelodysplasia as part of those syndromes. Myelodysplasia can occur due to exposure to teratogens, so in particular excessive alcohol intake, as well as a mother who takes valproic acid, which is an anticonvulsant medication, have been associated with increased risk of spina bifida. And finally, what probably gets the most attention is the association with nutritional deficiencies, and specifically inadequate levels of folic acid. And so this is why in all women of childbearing age, it's recommended that they take some sort of a vitamin with folic acid. And so many foods now are enriched with folic acid because, unfortunately, these neural tube defects actually occur usually before the mother even knows she's pregnant. So it doesn't really do any good for her to begin taking those vitamins once she knows that she's already pregnant. So it's important to have good folic acid intake prior to even getting pregnant. which again is why we recommend all women of childbearing age, even if they're not planning on getting pregnant, take folic acid. And also you'll see lots of different grains and foods that are enriched with folic acid. So how is myelodysplasia diagnosed? Well, it can be diagnosed in several different ways. Early in the second trimester, parents can get a blood test, which is known as a maternal serum alpha fetal protein screening, or an AFP, and that will give the family an odds of that their child would have spina bifida. So it isn't a definitive diagnosis, but when we do that AFP screening, if it comes back and shows that the mother is at a largely increased risk of having a baby with spina bifida, we may want to go on to other testing. Ultrasonography is a very reliable way of diagnosing myelodysplasia. In particular, ultrasound in the second trimester can usually diagnose spina bifida by taking a cross-sectional view of the head and the ventricles, and specifically they look for what they call the lemon sign or the banana sign. And then finally, there is analysis of amniotic fluid, which is amniocentesis. This is a fairly invasive process where a needle is actually inserted into the abdomen to collect amniotic fluid, but that can definitively diagnose neural tube defects and other chromosomal abnormalities. And so this is usually often not done unless a mother has had other tests that suggest that they may be at risk for having a baby with spina bifida. And specific to spina bifida, having early diagnosis can be important because there are actually new surgeries that are being done in utero to correct the myelomeningocele. So this can be really improve outcomes to have early diagnosis, and then also to have that surgery if the family is the mother is a candidate for that surgery. So there are a number of impairments that are commonly associated with myelodysplasia. This is a very, very complex disorder and is associated with many impairments. No two children are alike, and so they'll be different in all children, but there are a number of impairments that can be associated with myelodysplasia. First, musculoskeletal deformity. Specifically, we often see spinal and lower limb deformities, including scoliosis, contractures, and a number of different orthopedic foot deformities often go along with spina bifida. Children with spina bifida often have low bone density, so we see osteoporosis. This can be related to their lack of weight bearing and weight bearing opportunities at young ages. We see motor paralysis in children with spina bifida. This can present, lesions can present resembling complete cord transections, incomplete lesions, and skip lesions. And in your book, Table 22.1 has detailed criteria for assigning motor levels based on manual muscle testing, so that may be a good resource for you if you want to know more. We also see sensory deficits. These aren't always clear-cut because sensory levels often don't correlate with motor levels. So there may be skip areas that lack sensation. So again, although some of the times these lesions can actually resemble spinal cord injuries, they're typically not as clean. There can be lots of different skip lesions and skip areas. Hydrocephalus is a common impairment associated with spina bifida. This refers to excess cerebral spinal fluid, which actually contributes to the lemon and the banana signs that are often seen on ultrasound. These can also be associated with the caudal displacement of the hindbrain through the foramen magnum, and this is known as the Arnold-Chiari type 2 malformations. This is something that's commonly seen in children with spina bifida. Children with spina bifida can have a range of cognitive dysfunction, or of cognitive function from average or above average to low and low intelligence, and so we really see a range, but we do know that kids, particularly those with hydrocephalus, are at risk for cognitive dysfunction. Language dysfunction is also often seen in children with spina bifida. Latex allergy is a common finding, that children with spina bifida have greater risk of latex allergies than the general population. Although often children with spina bifida have good upper extremity coordination and skills, sometimes we do see upper extremity discoordination, so that can be an impairment that goes along with spina bifida. Visual perceptual deficits and cranial nerve palsies are also associated with spina bifida. And there are even more impairments. Oftentimes spasticity is part of spina bifida. Muscle tone in children with spina bifida ranges from flaccid to normal to spastic. So oftentimes you may see flaccidity as well. You may see progressive neurological dysfunction. This is often seen in children who have hydrocephalus and have a cerebrospinal fluid shunt, and maybe could be due to shunt dysfunction. Could also be due to a growth of lipoma on the site of repair, subarachnoid cysts of the cord, or spinal cord tethering. So when we see progressive neurological dysfunction in children with spina bifida, we really want to look further to see what's going on. Children with spina bifida frequently have seizures. About 10 to 30% of children with spina bifida will have seizures. Neurogenic bowel and bladder is seen in almost all children with spina bifida. Less than 5% of children with spina bifida develop voluntary control of their urinary or anal sphincters. Skin breakdown can be seen in children with spina bifida, particularly those who are in wheelchairs. Pressure sores tend to be more common in adulthood, whereas ammonia burns from having incontinence while sitting in a wheelchair, as well as friction burns from kind of crawling around on the floor and just basically getting rug burns on the legs, are more common in younger children. And finally, obesity is frequently seen in spina bifida. Decreased muscle mass coupled with lower limb inactivity means that children with spina bifida have lower caloric needs and have more of a struggle keeping weight off. So when examining the child with spina bifida, first we're going to start in infancy, and really our focus at this age is promoting parent-child interactions. Parents are often very fearful of handling their child with spina bifida, particularly when they do have that lesion on the back. So we really want to help parents become more at ease in handling their child. We want to look at tone. Obviously, we want to see physiological flexion in our young babies, but we sometimes in this population will end up seeing hypotonia. So we just want to look at tone, make sure that what we're seeing is typical physiological flexion, that we don't have too much tone, also that we're not floppy. We want to check for dislocated hips and foot deformities. These are very common in children with spina bifida, so we want to take a look at those and see if there's any way that we can address those. We want to watch the child for spontaneous activities and as well as eliciting some movement. So we kind of want to see what the child does and what the child can do. We also want to look at strength. Again, in infancy, we're not going to be able to manual muscle test, so we're probably going to be looking at more functional strength, or even just judging strength through handling and assessment of active movements. And then finally, the best we can, we want to assess sensation. This can be really challenging in the infant, but we want to try the best we can to see if we can assess where that child is in terms of their sensation. As the child moves into a toddler and preschool age, we want to really focus our examination and treatment on environmental exploration and mobility. So we want to assess range of motion, and we want to look at functional strength testing. By age 2 and up, we should be able to do some light touch and position sense. So the child should be able to follow some instructions and give us some feedback. We will probably want to do some standardized testing for fine and gross motor development, particularly as we look at trying to qualify a child for early intervention or school-based services. And then we really want to start thinking about self-care skills at this age, so we're going to look at activities of daily living, starting to learn to brush teeth, feed themselves, dress themselves, figuring out how to manage toileting, all those types of things. As we move into school age, we really start to focus on advancing mobility, activities of daily living, and as well as socialization. And so our examination is going to focus on joint alignment, muscle imbalance, contractures, muscle extensibility, and posture. At this age, we really want to look at all those things, and we're really thinking about preventing secondary impairments. We want to assess sensation, coordination, and fine motor skills. We certainly want to work on and assess mobility and gait. We can, at this age, start to do some reliable strength testing. and again, looking at ADLs. And we also, as children reach school age, their community and their world sort of gets bigger. So we really want to assess the accessibility of their environment. Are they able to access all the areas of their school? What are the places that they like to go in the community, whether it be with their friends or their family? We really want to assess accessibility and try to help families problem solve when accessibility is less than ideal. And as we move into adolescence and childhood, we want to really focus on community mobility as well as independent adult living. So again, we're going to be focusing on range of motion and strength. We want to make sure that we're avoiding those secondary impairments and that we're maintaining our function as much as possible. Bed mobility, floor mobility, and transfers are all going to become an issue at this age. As you can imagine, as children move into adolescence and adulthood, they get much larger, and so if they are dependent for transfers, this can become a lot bigger burden on families and caregivers, so we really need to try to problem solve some of those things. And then even in children who are able to walk, we may want to explore wheelchair mobility at this age. Again, as children with spina bifida, they get older, their demands of getting around in the community are bigger. They're not just having to get around in the house or even in the classroom anymore. They may want to have a job and go out in the community, get on and off of a bus. They may want to learn to drive. They may want to go to the mall with their friends. All of these things start to come into play. And so we may want to consider whether a wheelchair may not be a good option, at least for some community mobility. So whether that's a manual chair or a power chair, we just really want to assess whether that would allow for more independence. And looking at goals and interventions for all of these different ages, we sort of touched on them as we talked about examination ideas. But first, in infancy, the number one goal is going to be family education. We really want to educate the family on what they can be doing with their child for handling, positioning, and to promote development. And so we want to work on handling. We want to just facilitate kind of normal sensory motor experiences. So we want to get that child whether that is through positioning with using towel rolls and trying to get them where they can bring their hands together, or using support so that they can sit up, helping them with tummy time and learning how to crawl and stand. We just want to facilitate all of those sort of experiences. And in infancy, we really want to start thinking about mobility. So we want to prepare for mobility, whether that will mean walking with an assistive device, or using some sort of wheeled mobility such as a wheelchair. In preschool, we obviously want to address impairments that we see. We want to prevent secondary impairments. We want to, at this age, really promote play and self-care. So we want to really promote socialization and activities of daily living at this age. And by preschool, we should have identified an effective means of independent mobility. So again, this could be walking with a walker or forearm crutches. It could be pushing a manual chair or driving a power chair. But at this age, we certainly want to see the child be able to explore his or her environment. And then finally, in school age and adolescence, we want to maintain our achieved level of activity and prevent deterioration. There are a number of things that can contribute to deterioration, going through puberty, bones growing faster than muscles, and just increased demands, physical demands of living life as a school age child or an adolescent can all contribute to deterioration. So we want to really focus on preventing that. We certainly want to address seating and mobility issues. So for kids who are in wheelchairs, we want to make sure that we keep up on that and that we give them an independent way to move around. If we have children who are upright and using walkers and crutches, we want to stay on top of that and make sure they're safe. And we want to promote participation in age-appropriate sport and activities at this age. Recreation and fitness and health are very important. We want to teach children to kind of manage their health and to enjoy activity and fitness, and particularly in this group where obesity can really be a problem, we really want to emphasize the importance of just activity and health and wellness. And your textbook has a nice section on outcomes based on lesion level. So if you want to know more about sort of how to come up with a prognosis for children based on different lesion levels, or how you would know or have the idea of whether a child is going to be more appropriate for walking using an assistive device or a wheelchair. You can really look over that section. It does a nice job of kind of saying what we can expect in each of those levels. And this information can really help guide the physical therapist in realistic goal setting and program planning. So I would really encourage you to take a look at that in your textbook.